डॉक्टर पीयूष
हाँ।
अ, आप होना मैम।
हाँ, I'm start कर रही हूँ.
हाँ कर दो, स्टार्ट मैम कर दो, सर जी डॉक्टर पीयूष जी।
Okay. So good evening, everyone. We are here to discuss another case in the PG clinics today. Very important, a very important symptom that kids normally come to us with, that is anemia. We have already discussed approach to anemia in many different lectures, but every case is different and every case requires a very streamlined approach, and the more cases you see, the more you learn. So today we discuss another case where we are dealing with a child who has come to us with severe anemia. So Piyush, you can share your slides and we can start. Any questions, please feel free to put it in the chat box.
Good evening, everyone. Am I audible?
Yes, you're audible.
Good evening, everyone. Today, I am going to present a case related to how to approach to severe anemia. Master A, 11 years old male boy, born of first order by non-consanguineous marriage, resident of Talkola, West Bengal, Hindu by religion. His informant being mother and reliability is good. Presented with chief complaints of fever for 5 days, paleness noticed by mother since 5 days, easy fatigability since 5 days, yellowish discoloration of eyes for 5 days, and dark colored urine noticed 2 days back. History of present illness. Child was apparently well before 12 May when the child developed fever, which was not associated with chills and rigor, partially relieved with medications. During the course of illness, mother noticed paleness, which was acute in onset and progressively increased. Child also complained of easy fatigability aggravated on walking and exercise. Child also had yellowish discoloration of eyes, which is acute in onset and progressive. 2 days prior to coming here, child had one episode of dark colored urine. Negative history. There is no history of chills and rigor associated with fever. There is no history of pain in abdomen, limbs, chest, headache. There is no history of bone pain, weight loss. There is no history of recurrent infections or bleeding from other sides, petechiae or purpura. There is no history of decreased urine output, facial puffiness, or difficulty feeding. There is no history of passing warmth in stool. There is no history of pica. There is no history of blood loss in stools, black tarry stools, blood in vomitus. There is no history of loose stools, while stools.
Okay.
Treatment history, child was shown locally, which for which investigations were done, which was infective workup was done, which was normal. Child was given symptomatic treatment for fever. As per mother, child hemoglobin was very low, so child was referred to Siliguri. In Siliguri, further evaluation was done, and child received blood transfusion. As per mother, there was difficulty in cross-matching the sample for blood transfusion. Child was referred here for further evaluation and management.
So based on your chief complaints of the child and the course until now, what do you think are we dealing with here? Like, how do you delineate and stepwise?
As per chief complaints, child complained of fever, paleness, and easy fatigability. Paleness and easy fatigability points towards anemia, and yellowish discoloration points towards hemolysis. And fever infection might be there.
Okay.
In a negative history, there is no history of chills and rigor. So infective causes like malaria is ruled out.
Okay. So here we are
And
dealing with a child who has some symptoms of anemia and
with
symptoms of jaundice with
jaundice,
fever.
fever.
Yeah. So it's like anemia plus fever with jaundice. So why did you take, like, just explain your negative history? Why did you ask for each of the negative history points?
Uh, First, I asked about chills and rigor. Anemia with jaundice occurs in certain infectious conditions like malaria. So I asked regard whether the fever was associated with chills and rigor.
Okay. Malaria and what else? Sometimes even lepto
Ka-
can have.
le- Kala Azar.
Yeah, Kala Azar can have. Okay. Next.
Next, at 11 years of age with anemia, jaundice, sometimes sickle cell anemia also occurs. So rule out pain. So I asked regarding pain abdomen and pain in limbs and chest and headache to rule out sickle cell anemia.
Okay. And one more history that you missed. You have told it, but you've missed it, which is pointing to something important.
Cough and cold, viral infection.
No, in your history, you have anemia, you have paleness, you have jaundice,
Easy fatigability.
and one more thing, you have also a history that the mother is giving of dark
Dark,
urine, right?
dark colored urine. Yes,
Yeah,
ma'am.
so that is a very important history along with this. So what does that signify?
Hemolysis.
Some form of hemolysis that is happening. Okay, you've said it can be malaria also. True. What else? Now come down to all your negative history points.
I asked regarding bone pain, weight loss to rule out any malignancy.
Okay. But malignancy will not have the dark colored urine, very
Yes,
common,
ma'am.
and so much of jaundice. Okay. Still, but then coming down again.
Recurrent infections and bleeding from other sides to rule out pancytopenia. Other cell lineage is deficient or not.
Okay.
And decreased urine output, facial puffiness to rule out whether there is congestive cardiac failure because of anemia.
Okay. Okay.
And
More common, like the above in your list would be causes where you expect a hemolysis to happen. The hemolysis is probably causing the jaundice and there's also anemia. Okay, moving forward, we can go ahead and we discuss the points later.
past history. There is no history of blood transfusion prior to this episode. Child has been operated for inguinal hernia at 5 years of age. There is history of swelling of peanut size on left side of neck, noticed in 2023, for which the child got homeopathic treatment for 2 years. Family history. There is no history of gallstones or blood transfusion in family members. No history of abdominal surgery in family members. There is history of leukemia in father's first cousin.
Okay. Why did you ask for this specific history?
Blood transfusion to rule out any hemoglobinopathies in family members.
Okay.
And abdominal surgery for like in hemoglobinopathy, sometimes splenectomy is done to rule out that.
Okay, which hemoglobinopathy will you do splenectomy? Which condition, like why did you ask the history for splenectomy? Okay, but which conditions will have this history that the family will give you of gallstones or splenectomy?
Hemolysis, massive hemolysis is there.
More common will be your membranopathies, no? Something like
Yes, ma'am.
spherocytosis.
Spherocytosis, hereditary spherocytosis.
So because now that we diagnose these cases very frequently, but earlier there was not much of diagnostic modality. So we have seen patients where when we've gone back and asked the history, we have had a history coming up कि father को भी transfusions लगे थे, multiple transfusions in the father, and a grandfather had a history of a splenectomy or a gallstone, cholecystectomy. So that just streamlines and pinpoint, just narrows down your diagnosis, that you're looking at some of these causes. So that is very important. One more thing, not very common, but when you're dealing with a hemolytic anemia, very important to ask for a history of neonatal jaundice.
Yes, ma'am.
Okay, again, neonatal jaundice can be seen in all these conditions. Okay. Yeah, moving forward.
Birth history. Child was born at full term by normal vaginal delivery. Child cried immediately after birth. Birth weight was 3.5 kg. There is no history of an ICU stay. There is history of neonatal hyperbilirubinemia, but the child is not received phototherapy for that. Child development is appropriate for age. Child studies in class 7 with good scholastic performance. And dietary history, there is a 28% deficit in calorie and 12% deficit in protein. Child is immunized. Immunization is complete up to 10 years of age as per IAP schedule. Last vaccine was taken was TD booster. BCG scar mark is present. Summary. Master, a 11-year-old boy from Dalkola, West Bengal, born of a non-consanguineous marriage, presented with acute fever for 5 days, pallor associated with easy fatigability, and yellowish discoloration of eyes for 5 days, dark colored urine for 2 days. He was transfused once at Siliguri before referral. There was difficulty in cross-matching the sample as per mother. Past history includes inguinal hernia surgery at 5 years and a neck swelling treated with homeopathy. So
Okay. Summarize the history, just pull out the main points from the history. So Master A, so and so, 11-year-old boy with complaints of fever, easy fatigability, jaundice, and dark colored urine, and also difficulty in cross matching later. So you have to be very selective when you are summarizing your history and then give your DDs. So what will be your DDs for this case?
First is autoimmune hemolytic anemia.
Okay.
Next, infectious hemolysis like malaria, viral. Hemoglobinopathies like sickle cell anemia, glucose 6-phosphate dehydrogenase deficiency, hereditary spherocytis, and bone marrow disorders such as leukemia.
Did you ask for a drug history in this patient?
For fever, they have just taken NSAIDs and nothing else.
Okay. Okay, going on further, okay, we'll come to each of the differentials later. Then coming to the examination.
After taking consent, child was examined in sitting posture. Vitals, pulse was 110 per minute, regular normal volume. There was no radial or radiofemoral delay. Respiratory rate was 22 cycles per minute, regular normal rhythm. BP was, blood pressure was 110 by 70 mm Hg in right arm supine position. Temperature was 98 degree Fahrenheit in axilla. Weight was 34.2 kg, lies in minus 0.5, Z score, height 154 centimeter, and BMI 14.4.
What is the importance of anthropometry in a case of anemia?
To rule out with in certain nutritional anemias, there will be poor weight gain. In hemoglobinopathies, there is also poor weight gain. In short stature, in certain congenital anemias, there is short stature.
Which congenital anemias will have short stature?
Fanconi's anemia.
Okay, and something more?
And diamond flag.
Okay. No, under other cases, like when is the anthropometry important? When you're dealing with a anemia which has a chronic, like anemia secondary to a chronic disorder, no?
Thalassemia major.
Not thalassemia major, it's like a chronic liver disease or a chronic renal failure or something.
Anemia, yes, ma'am.
Yeah, something like a celiac. Okay, something like, ulcerative colitis, Crohn's, the child is not growing. So anemia secondary to chronic disorders will have growth retardation.
Growth retardation.
That tells you that the anemia has been going on since a long time. That is the importance of anthro. Okay, go ahead.
Head-to-toe examination. Pallor of severe grade present, checked in lower purple conjunctiva and palm. Icterus present, checked in sclera. There is a single node of size 1 into 0.5 centimeter in left posterior triangle of neck. Oral cavity is normal. There is no petechiae. Spine normal. There is no skin hyperpigmentation. Genitals are normal.
What head-to-toe examination will you do in a patient of anemia?
First, head-to-toe examination. First, we'll check Head size. In certain conditions, there is a frontal bossing.
Okay. In which conditions will you get frontal bossing?
Thalassemia.
Okay. Other features which you will get in thalassemia?
Hemolytic facies.
Like what are hemolytic facies?
Depressed nasal bridge, prominent maxilla,
And
crowding of teeth,
malocclusion of teeth,
malocclusion of teeth,
blood prominence, then the skull shape you have
skull
told.
shape.
Okay, some of the features. Anything else, anyone? What else? Head to toe examination. Okay, hemolytic facies. Then
Microcephaly in congenital anemias.
okay, microcephaly in congenital anemia. What congenital anemias? Matlab, what is the spectrum? Which something is more specific?
Fanconi's.
Fanconi's. What else do you see in a case of Fanconi's anemia? Head to toe examination में क्या क्या दिखेगा?
Cafe ole spots दिखेंगे मैम.
Okay, and
Absent thumb. Sometimes syndactyly will be there.
Okay, skeletal abnormalities, thumb abnormalities, short stature you had
Short
told some
stature.
time back. Yeah, it said hyperpigmented. That is more specific. Cafe au lait spots. Others, any dysmorphism that you see in Fanconi's? You can type your answers in the chat box. Something with the eye, something with the face. The typical faces that you see in Fanconi's anemia. Okay, there's a bird-like facies which you can see almond-shaped eyes and a certain dysplasia. You can identify a Fanconi patient with Fanconi anemia when the patient walks into the OPD. They have this classical facies that you have. Everything is given. If you just open your Nelson, it's a big table and all the abnormalities associated with Fanconi anemia is given there. Okay, and what else? Genitalia, why did you look for? Again, in inherited bone marrow failure syndromes, you can have genital abnormalities. Okay, going forward. And for anemia, what else do you see? Platinikia.
Quilonicia.
Then for your vitamin B12 megaloblastic anemias, what else? What can you see?
Chillosis, angular stomatitis. Tongue.
So once you're doing a head-to-toe examination in a child, now I agree the child has anemia and jaundice. Don't straight away jump when you're doing a head-to-toe examination in a child with anemia. As per the causes, you will have to just put down your head-to-toe examination as per the causes of anemia. You'll never miss any of them then.
Okay.
Okay. Then going forward.
Systemic examination. On inspection, abdomen was distended. There was no visible peristalsis. Umbilicus normal in position. There is no umbilical discharge. Hernial orifice is normal. All quadrants of abdomen moves equally with respiration. Skin over abdomen normal. No scar and sinuses. There is no dilated veins on abdominal wall. Genitalia normal.
Okay.
On palpation, superficial palpation, there is no local rise of temperature, abdomen soft, no tenderness, no guarding rigidity. On deep palpation, liver felt at 3 centimeter below right costal margin at mid clavicular line, soft in consistency with a smooth surface, well-defined margin, no tenderness present. Spleen palpable 2 centimeter below left costal margin, soft in consistency. On percussion, liver span was 10 centimeter, no free fluid. On auscultation, bowel sounds present, kidneys palatable, external genitalia, bilateral testes palpable, normal in size and position. There is no scrotal edema.
Okay, so you have a liver palpable and you have a spleen with it. Liver and spleen. What is the liver? 2 centimeter, if I'm not wrong, right?
Yes, ma'am.
And spleen of 2 centimeter. What does this probably indicate? I mean, not a short thing, but what does a spleen size of just 2 centimeter indicate? It is going less in favor of a hereditary spherocytosis. Normally, if a child has severe anemia and jaundice with a hereditary spherocytosis, you are expecting a larger spleen to be seen. Okay, expecting a much bigger spleen, splenomegaly. Okay, next. You have done your systemic examination.
Yes,
Now
ma'am.
what is the now,
Uh,
okay.
In CBS, there was no, as one as to present no murmur, see, no murmur auscultated, and in respiratory system was no abnormality found. Central system, CNS system was normal.
Okay. So now you summarize your case.
Master A 11-year-old boy presented with progressive pallor, easy fatigability, and dark colored urine for 2 days. A history of one packed red cell transfusion prior to referral. There was difficulty in cross matching the sample. On examination, child has pallor, icterus, small left posterior cervical lymph node, hepatomegaly 4 centimeter below right costal margin, and mild splenomegaly 2 centimeter below left costal margin.
Okay. So your differential.
I will first go with autoimmune hemolytic anemia,
Okay.
and then infectious hemolysis
Okay.
and hemoglobinopathies and G6PD. Hereditary spherocytis I will put later because no such features is found, and bone marrow disorders.
Okay. Now you tell me how will you approach this case. Okay, so this child comes to you, you found out anemias and jaundice and this dark colored urine. So how will you approach the case?
I will like to investigate further.
Hmm.
Uh, so first we will do CBC.
Okay.
In CBC, we found out that the hemoglobin was low, 6.3, and TLC was normal, so no signs of infection is there. And platelet count is also normal. MCB is slightly raised,
Hmm.
and retic count is raised, and unconjugated bilirubin is high.
First, you tell me what are the tests. You just go back and tell me what are the panel of tests that you will order for this patient.
First,
Any,
we'll
yeah,
first
anyone
we'll
put the
do
answer chat box. Yeah. Yes, please.
first we'll do infective workup to
Okay.
rule out any infective causes.
Okay. First test. A child has come to you who is looking very pale, easy fatigability, jaundice. First
CBC,
test.
CBC,
Anything be more specific?
hemoglobin,
Mm-hmm. What is the full test that you will order? You will just order a CBC.
CBC with peripheral smear,
We'll need a CBC with a peripheral smear. And second,
um, liver function test,
something above CBC, PS, and
uh, retic count,
retic count. A CBC, a different CBC with a differential, a peripheral smear, and a reticulocyte count. Now you tell me what will you see in the CBC, what will you see in the peripheral smear, and what will you how and the retic count. How will you interpret?
In CBC, first we'll look at the
ये
hemoglobin.
rule out करने के लिए तुम्हारा hemolytic anemia और बाकी hemolytic anemia rule out करने के लिए what will you see in the CBC, PS, and retic?
For ruling out hemolytic anemia, in CBC, we will see hemoglobin is decreased or not. And retic count for in hemolysis, reticulocyte count increases.
Okay, CBC. How will you read a CBC? First parameter, hemoglobin.
Hemoglobin,
Second
then
parameter,
TLC,
okay,
then platelets,
okay.
then MCB,
RBC count.
RBC count.
क्या होगा RBC count?
Hemolysis में RBC
RBC count will be
normal,
RBC count will be decreased.
decreased.
अनीमिया है ना, RBC count will
हाँ,
be decreased. अनीमिया है 8 है सपोज बच्चे का हीमोग्लोबिन और RBC count is 5.7. What will be your DD?
RBC count is decreased. Hemolysis is there, man. And
एक बच्चे का अगर अनीमिया है 8.3 है, अनीमिया है, and the child is coming to you with RBC, and you see the RBC count is 5.6 million. Rule of three क्या होता है बता?
Rule
What
of
is
three, ma'am. RBC into 3 times is hemoglobin,
हम्म
and hemoglobin 3 times is hematocrit.
हेमाटोक्रिट. सो इसमें अगर अनीमिया किसी बच्चे का 8 है and the this count the
RBC.
RBC count is 5.6, it's not following the rule of three, no? So
Yes,
what is
ma'am.
the first thing that should strike you?
न्यूट्रिशनल डेफिशिएंसी हो सकता है.
क्या हो सकता है?
IDA, iron deficiency anemia.
Iron deficiency anemia will have a low RBC count. If you
Yes.
have anemia with a high RBC count, the first thing that should strike you is, are you dealing with a thalassemia trait?
Yes, ma'am.
So that is the importance of looking at the RBC count. Now coming to this again, hemolytic anemia, HB will be low, RBC will be low. What will be the MCV?
MCV will be normal,
MCV will be normal to slightly raised.
slightly raised.
Your cells are getting lyse, the newer cells are coming. So MCV will be slightly raised. What will be the MCHC, and why do you check for MCHC? कौन से कंडीशन में तुम्हारा MCHC is told to be a bedside marker?
Hereditary spherocytosis.
Yeah, so you check for the MCHC. MCHC in hereditary spherocytosis is what
Raised.
is the MCV raised? Why is the MCV raised?
Don't know.
The MCV is anyone in the chat box? The surface area of the cells is decreased, no? It's a membranopathy. So the biconcave shape है वो नहीं होता, the
Spherical.
hemoglobin is concentrated. So the MCV or the MCHC goes high. Okay, next PS में क्या देखोगे?
अगर मैम हेमोलाइसिस हो रहा है तो रेटिकुलोसाइट्स विल बी इंक्रीज्ड. रेटिकुलोसाइट न्यूक्लिएटेड सेल्स विल बी प्रेजेंट.
Nucleated cells are present in which hemolytic anemia?
ये हेमोग्लोबिनोपैथीज.
Like
थैलेसीमिया.
thalassemia. Okay. And reticulocytes कैसे दिखते हैं? You can see the normal reticulocyte with your stains. Or you use anything special for reticulocyte to view a reticulocyte? Read about the stain which you see to which you use. Reticulocytes require special staining. So which is the stain used to see a reticulocyte? Okay. Spherocytosis के causes बताओ.
स्फेरोसाइटोसिस, इम्यून हेमोलाइटिक एनीमिया,
Autoimmune hemolytic
autoimmune,
anemia. Yes.
and hereditary spherocytosis,
Yes.
thermal injuries, and
There is a long list of hemolytic or the conditions which can cause hemolytic anemias. So, hereditary spherocytosis, your autoimmune, ABO incompatibility. ABO incompatibility can cause autoimmune hemolytic anemia, then your hereditary spherocytosis, then your thermal burns, clostridial sepsis, Wilson sometimes can cause. Okay, so these are long lists. There's a list of conditions where spherocytes can be seen. First will be your hereditary spherocytosis, then your hemolytic anemias and ABO incompatibility. These are your main causes. Okay, and anything else that you want to see? One of your DDs was sickle cells. So you will want to see sickle cells in the PS.
yes, ma'am.
Right? Anything else that you can see in the PS?
For G6PD, sometimes bite cells will be there.
Okay, and Heinz body and bite cells.
Heinz.
They require supravital staining. Anything else? In hemolytic anemias only that you can see in the PS?
Cystocytes, ma'am, sometimes microangiopathic hemolytic.
Okay, schistocytes. Anything more? When it's a cold hemolytic, cold disease.
Agglutination will be there, ma'am.
तो you can see agglutination. And what agglutination reflect कैसे होगा तुम्हारे CBC में?
Hemoglobin will be
Agglutination से क्या होगा? Your MCV will go up.
MC will go.
You will see the MCV is very high, more than 100, 105, disproportionately high, which can happen in agglutination. So whenever you are saying, तो इसलिए CBC and PS का importance is all of this will be your peripheral smears finding. So good peripheral smear to report a good peripheral smear is extremely important. Okay, so first हमने कर लिया CBC, DLC, retic count. Retic count को क्या होगा? What will happen to the retic count?
In hemolysis, it increases.
Okay, and how do you your hemoglobin of this child you showed is 6.3, and you have a retic count of say 10% or 11%. Is that the absolute value that you will take, or you'll do something?
We'll do corrected reticulocyte count,
What
ma'am.
is the formula for a corrected reticulocyte count?
Percentage retic count into observed hematocrit by normal hematocrit.
Okay, so what is the formula for a retic count? Reticulocyte percentage
Into
patient's
observed patient's hematocrit by normal hematocrit.
by normal. So you will always you have to calculate the corrected reticulocyte count. Whenever there's anemia and you have a reticulocytosis which is high, you still have to use a corrected retic count. CBC हो गया, retic count हो गया, और PS peripheral smear हो गया. What else? We are coming back to our investigations.
Next, for hemolysis, we will do direct agglutination test.
Okay. And what is also a straightforward question? What is the workup or your list of investigations which you will send in a case of autoimmune or in a case of hemolytic anemia?
CBC with PS retic count, then DAT, then infections related to this malarial antigen, and for viral infection, Epstein-Barr virus and mycoplasma pneumoniae.
Simple things first. CBC हो गया, peripheral smear हो गया, retic हो गया, liver function क्या?
Yes, ma'am. Jaundice,
Yes.
total bill.
Important, no, to look for a direct hemoglobin, direct या indirect cause.
Yes, ma'am.
Then marker of cell turnover.
क्या ma'am?
A marker of cell turnover, LDH.
LDH, ma'am. LDH will be increased in hemolyzed.
Then that you have said DAT.
Yes, ma'am.
DAT क्या? DAT, and if DAT is positive, how do you do DAT? How do you do check for a direct Coombs test, and what is direct Coombs test and what is the indirect Coombs test?
Indirect Coombs test, antibodies are attached to RBC, and indirect is checked in plasma.
In वापस से बताओ.
And direct Coombs test is checked in RBC on the surface of RBC.
Yes.
And indirect Coombs test is checked in plasma.
In which cases will you check for a indirect Coombs test? The सारे cases में will you order a indirect Coombs test, and there's something specific when a specific scenario when you order for an indirect Coombs test?
RH incompatibility.
Yeah, so RH incompatibility में baby में you do DCT and you check for ICT in the mother. How do you do direct Coombs test?
Bodies are attached to RBC surface.
How do you check? What do? You suspend the cells in what?
Gel card technique is used.
Okay, gel and card, that is right. But how do you suspend the RBCs? The RBCs are suspended in an anti-human globulin.
Yes, ma'am, anti-human.
Yeah, because that is necessary, because एक RBC अगर एक होगा तो you will not be able to appreciate the agglutination. So what this AHG does, it will bring the then it coats on the surface of the RBC. It will get all the RBCs together so that you can appreciate the agglutination. So that is direct. So direct में तो you are appreciating the antibodies in the surface of the RBC, and indirect में you are appreciating the antibodies in the serum of a patient. ठीक है, direct Coombs test हो गया and indirect Coombs test हो गया. More, what other tests?
Then urine for hemoglobin will check.
Urine
Because-
for hemoglobin, something, okay. And what else? What is haptoglobin?
Haptoglobin is decreased in hemolysis. It binds when there is a breakdown of hemoglobin. It binds with um, heme.
Okay, so what will happen to the serum haptoglobin levels?
It will decrease.
It will be decreased. Okay. What else? If there is intravascular hemolysis, you will have hemoglobinuria, hemosiderin. What is G6PD? G6PD causes what kind of hemolysis?
Intravascular hemolysis.
Intravascular. Good. So what about warm? So now you have hemolytic, a picture of a hemolytic anemia. And I am also, what is the mechanism of action in a hemolytic anemia? What is happening to the cells?
Antibodies.
So the cell is getting coated with antibodies, and
then there is a lysis, or then there is either extravascular hemolysis or either intravascular hemolysis.
most common is extravascular hemolysis. Splenic macrophages, it's getting destroyed.
Engulfed.
Engulfed by them, or macrophages are doing what? They are, just taking off parts from the antibodies and the parts of the RBCs. So RBCs are becoming small and spherocytic, so microspherocytes can be formed, and these microspherocytes then cannot go in through the splenic capillaries and they get lysed. So one of these is the way, and to a lesser extent they can also get destroyed in the liver by the Kupffer cells. So main organ of hemolysis is the spleen. That's why in extravascular hemolysis there'll be a huge splenomegaly that we see. Okay, now coming to hemolytic anemias, what if this patient now has anemia and is also showing his platelet counts is 80,000? What are you thinking of in this case? Hemoglobin is also low and thrombocytopenia. So anemia with thrombocytopenia, and your DAT is positive. So it's an autoimmune hemolytic anemia with a thrombocytopenia. What condition are we thinking about? Anyone? Autoimmune hemolytic anemia plus thrombocytopenia. What is the condition? We are looking at Evans syndrome.
Yes.
So normally if a patient comes to you with a autoimmune hemolytic anemia, you always have to look for other systems and other causes also, because it's an autoimmune phenomenon. So the autoimmunity can, be subjected to multiple organs and multiple cell lines. So the patient can either remain as a AIHA case, or they may progress to have the other cell lines involved or other systems also involved. So you always have to check for secondary causes also. Now, what are the causes of autoimmune hemolytic anemia? That will give you the causes to look for. So what are the causes of warm hemolytic anemia, autoimmune hemolytic anemia?
First is idiopathic.
Okay.
Second is viral infections like IgM, mycoplasma.
Okay. They will cause, more commonly, it will be associated with the cold type of hemolytic anemia. Okay. Then quickly, it can be the primary, it can be secondary. Secondary can be due to infections, multiple infections, viral infections, EBV, CMV, or hepatitis spectrum. Everything can cause. Then drugs. What are the drugs commonly associated with hemolytic anemia?
NSAIDs.
And
Sulfa cotrimoxazole.
Okay, and autoimmune hemolytic anemia, warm, cephalosporins.
Cephalosporins.
Yes. And what else? What are the drugs हो गए, infections हो गए, primary cause हो गया, और certain malignancies can expose you to, like lymphoproliferative syndromes, Hodgkin's lymphoma, all that can also cause AIHA. And autoimmune conditions.
Autoimmune
Autoimmune conditions can
SLE.
SLE, very good. SLE and You
mixed
have a long list of causes, no? SLE, ulcerative colitis,
ulcerative
rheumatoid, scleroderma. All these rheumatological conditions can be associated with a autoimmune
autoimmune.
anemia. Okay. And okay, so these are some of your causes. Now, something else. If a child is coming with any autoimmune condition, autoimmune hemolytic anemia, it is always necessary to work up the child for an underlying primary immunodeficiency disorder. Which immunodeficiency can come with autoimmune with autoimmune features? अब यही बच्चा है. Suppose what is his age? Your case is
11
how
years. 11
11.
years old.
And your old boy with autoimmune picture, what PID, underlying PID can you suspect in this child? कौन से PID में autoimmune features होते हैं जो late present करता है? CVID.
CVID.
Variable immunodeficiencies. Common so CVIDs have a later presentations and they can often come with all these autoimmune features. So always rule out primary immunity. There's one message that you have to take back is always rule out primary immunodeficiency in a case of any autoimmune anemia or thrombocytopenia. So always just good way to do is the immunoglobulin profile and the lymphocytes that you can check for. Any patient who comes with a autoimmune condition very early infancy, in a neonate, always rule out torch infections or early infancy or multiple family members involved or anything odd that you're thinking. Always get a genetic workup done. Okay, just by the by, all of these. So now how do you approach? वार्म हो गया, कोल्ड हो गया, फर्दर क्या टेस्टिंग करोगे? मोनोस्पेसिफिक डैट तुमने बोला पॉजिटिव आएगा. सो what then you do a monospecific DAT.
Monospecific.
What antibodies will come positive if it's a warm and what in a cold?
In warm, IgG will come positive.
Okay. And
And C3D.
Okay, so IgG commonly either isolated or associated with a complement binding antibody. So IgG and C3D. What about cold?
IgM will be positive.
Okay, IgM will be positive. Even complement bound antibodies can come positive. So you'll do a monospecific DCT. What is the percentage of patients with the AIHA who are DCT positive? And can you have DCT negative autoimmune hemolytic anemias? Or what is the percentage of auto DCT positive and DCT negative? And if so, what are the causes of a DCT negative hemolytic anemia? Anyone? Anyone in the chat box? So about 95 to 96% patients will have a DCT positive. So most common is a DAT positive autoimmune AIHA. But rarely you can also have cases where there is a DAT negative AIHA. So 1 to 2% patients can have a DAT negative AIHA. The most common causes are that either you are the antibodies are not at a threshold for detection, or you can have non-IgG which is the most common. No? So your cards and your tests are detecting the most common panel. So sometimes you can have IgA autoantibody, so which will not be detected by your the conventional method. So you have to use alternative testing methods. Or you can have the threshold of the antibodies or the sensitivity which is very low, which is not getting picked on your DCT. Most common is DAT positive, but 1 to 2% patients, it's a very rare entity, but also can have a DAT negative autoimmune hemolytic anemia. Okay, now coming to something else, one of the causes which we missed, ALPS, autoimmune lymphoproliferative syndrome. You will always, rule out ALPS in a patient who comes to you with a autoimmune hemolytic anemia. Okay, now coming to the treatment part, tell me how will you treat this patient?
For autoimmune hemolytic anemia, we will start with prednisolone.
Okay,
Steroid.
first, foremost, the most effective is steroids.
Steroids.
So how do steroids act?
They decrease immune reaction.
So what are they doing?
removing antibodies.
So they are silencing your FC receptors which are present in your macrophages. Okay. So what steroids you can use? Oral steroids, prednisolone.
And IV methylprednisolone we can use.
Dose.
Dose is 1 mg per kg. For 4 to 8 weeks.
For 1 to 2 mg per kg.
1 to
How
2 mg.
to give steroids in autoimmune hemolytic anemias? How long will you give? So you give it at least either you continue it at 1 to 2 mg
for
either
4 to 8 weeks.
So either till your hemoglobin is normalizing or till at least 4 weeks, whichever is earlier. But you can never stop steroids abruptly. So you always, so if you, what are the, how will you observe for responses? Response assessment kaise karte ho? Autoimmune hemolytic anemia mein. First, your reticulocytosis will go down. It will take about 5 to 6 days for your reticulocytosis to go down. Your hemoglobin will somewhere stabilize within the first week, and by the second week onwards, some rise in hemoglobin can be expected. So once you have a rise, your hemoglobin stabilizes and you have a rise, slowly you will taper down the steroid. Every 1 to 2 weeks, तुम slowly steroid taper करोगे. So normally, if you suddenly stop steroids, then almost all your patients are bound to have a recurrence. Slowly, every maybe 10% of the steroid dose, slowly up every 1 to 2 weeks, taper karoge, and the maximum that you will also give steroids in AIHs for 4 to 6 months in a tapering doses. What are the other treatment options in AIHA?
Intravenous immunoglobulins we can use.
IVIG you can give. Also in steroids, oral steroids and IV MPS also can be given. IV steroids also can be given. Okay. IVIG, yes, correct. What other options?
Immunosuppressive agents like cyclophosphamide, rituximab.
Rituximab, something else? Cyclosporin.
Cyclosporin.
Rituximab, what is your dose for rituximab in autoimmune hemolytic anemia?
375 mg per meter square.
So you give it how often? So you give 375 mg per meter square weekly for 4 weeks, and then you assess for response. Okay, so response can take about 2 to 3 weeks. Rituximab is a drug of choice. What are the other drugs? You can have cyclosporin, MMF, azathioprine. These are your other drugs. So some of the patients, so most of the patients respond to steroids. If not, the second would be IVIG or Ritux, but we see 15 to 20% patients who can go on to have a very resistant form of AIHA, and we may require other therapeutic options. Now, what are your treatment options for a cold antibody, like a cold autoimmune hemolytic anemia? And what else in warm? One thing we missed is if it's very severe, then splenectomy becomes your last option. Cold में तुम्हारे treatment options क्या है?
Cold is usually self-resolving.
Very good. And cold is secondary, normally secondary to some infection
some
or
infections. So we will treat infections.
Yeah, we'll treat the infections. You treat the cause. You wait for it to subside. And if you have to give blood, what will you do?
Warm
yeah,
blood.
Inline warmers.
Inline warmers will
transfuse blood through inline warmers. So that is one of the only reasons probably where you will warm the blood and give. Normally we have this notion which commonly goes on in the ward कि blood को warm करके देना है, but that is not the thing. जैसे ही blood bank से blood आता है, you really have to immediately, as soon as possible, connect the blood and start transfusing. This concept of warming the blood prior to giving it, it's a very long lost phenomenon. We don't do that, except this one condition where you warm your blood, which is a cold autoimmune hemolytic anemia. Splenectomy, does splenectomy help in cold AIHA? Splenectomy does not help in cold AIHA. Okay, because the destruction is not the spleen, it's a more complement binding and intravascular mode of hemolysis. So splenectomy does not help. So these are the main two causes for AIHA. What about PCH? Have you heard of the entity called PCH? Anyone? Piyush, what is PCH?
Paroxysmal cold hemoglobinuria.
Yeah, it's something very rarely that we see in children. So what happens and what is the test that you do? What are the antibody? What is the name of the antibody in PCH?
Donat Landsteiner.
Very good. Donat Landsteiner. So what happens?
After following a viral infection,
Hmm.
there is a hemolysis when there is a hemolysis.
So you will suddenly have a child with maybe it's after a overlying infection or a viral infection or something, a child who is coming to you with sudden onset jaundice and hemoglobinuria, dark colored urine.
Yes,
And
ma'am.
and it will most of the cases self-subside. So Donat Landsteiner is the antibody is mostly directed against the P antigen on the RBC, and it will bind to your RBC at 4 degrees and then gets washed away or neutralized when you get at the room temperature. This is something typical about the DL antibodies. What is PNH?
Paroxysmal nocturnal hemoglobinuria.
Okay, how do you diagnose PNH? What is the pathophysiology and how do you diagnose PNH? What is the pathophysiology in PNH?
Mainly at night, there is hemoglobinuria, ma'am.
What is the pathophysiology? क्यों हो रहा है? What is deficient? This deficiency of GPI anchored proteins. So your RBCs are getting lysed by your complement system. So there's intravascular hemolysis. And how do you check? How do you test for PNH? Anyone? How do you test for PNH? So you will test, there is a flow cytometric analysis of CD55 and CD59 that you check on your blood cells, and you will see whether that will give you a surrogate marker of the GPI anchored protein. So everyone please read and what are the features and what is the drug of choice in PNH. Read PNH, the diagnostic test which is followed, and what is the clinical features and how do you treat. So anything else in your case, Piyush? We want to.
No, ma'am.
Okay, so most important so we were discussing here a case of autoimmune hemolytic anemia, and what do you do while cross matching? This patient, the mother gave you the history, of difficult cross matching. So all these patients can have this difficulty with cross matching. So what do you do?
Phenotypic
So you have to do an extended
phenotype.
phenotype because there might be other antibodies and the least incompatible because if the child is coming to you with failure. So criteria for transfusing blood in a AIHA case is either the child is coming to you in a crisis, congestive heart failure or impending heart failure, the hemoglobin is less than 5. Otherwise, you will not transfuse these patients you'll transfuse them very judiciously because ek to cross match nahi hoga and there will be a difficulty in cross matching. Whatever you're giving, again the same, the hemolytic cycle, the vicious cycle can continue. So you will give the least incompatible blood, and always when you're getting such a patient, the blood bank will inform you, and then they process. So it takes longer for the blood to cross match. So transfusion should be very judiciously used in cases of AIHA. Okay, so just for AIHA briefly, you have to know the types, you have to know the causes of each, approach to hemolytic anemia. So here, because we are short of time, we could only discuss AIHA. So what are the membranopathies and everything else? What is the big classification of hemolytic anemias has to be described, and then an approach to stream-wise approach. So if it was a hereditary spherocytosis, and what are the tests? So every branch of that approach to hemolytic anemias will have a separate diagnostic algorithm. So you have to go through that. Any more question, anyone? Or else we end the session. I think we already crossed our time limit. Any questions from anyone? Okay, so then we end it for the day. Thank you, Piyush, and thank you
Thank you, ma'am.
everyone for this session. Yeah.